data collection group. To give you a little sense of our process, yesterday we brainstormed outcomes that we'd like to see into a long list. Then we consolidated them overnight like most of the groups. And then today we started out by discussing those outcomes and then voting on them using stickers. Then with those consolidated group of priorities, we went through the first, I believe, 4 of them, brainstormed actions underneath those actions so that they were more specific for each one. Then we voted on those actions, and then we chose 3 actions and then outlined kind of the major categories of what we should do with those actions. So we have 3 actions that we chose that we'll go through. And we think these are reasonably achievable, but we're hoping to get some feedback on that. So the first one, the first outcome that we discussed was development standardization of family health history collection tools, and really creating a task force of those vendors, academics, groups, institutions that already have family health history collection tools. Really, the outcome being standards or mandates for family health history collection and storage and portability. Really technology focused, though, rather than the content of the data. Let me go through the specific actions and for this one set, and then we'll stop after each one. So, because if you're going to comment that patients need to be involved, okay. So let me go through the whole thing, though. So the 3 actions we discussed under that outcome were this task force of existing tool providers, creators, creating a specific meaningful use 3 mandate around the technology, so specifically electronic health records and personal health records, but also how those interface with these other types of tools. And we left the specifics of that to the task force and to the group that did data connection, because we know that they were doing standards as part of their focus. And then the third one we felt was really important for collection was software to scan in family health history from paper forms as structured discrete data to meet those criteria. And we felt, at first this is magic, but there's a lot of magic happening in Silicon Valley, so ways to make that happen. The highlighted one is, this is what we wound up discussing for the next section. So the purview, we thought it was the tool developers' purview, we thought it was ONC's purview with meaningful use, and we thought in many cases professional societies set a lot of the standards that are currently used for collection by genetic counselors, and therefore set what's included within the existing collection tools. The stakeholders we thought should be involved, though, are also the genetic counselors themselves, that should be GCs, providers, patients, privacy advocates, and also the laboratories and vendors who eventually want to have access to that data as well, and therefore have an incentive to participate. The timeline, we thought, is as soon as possible. We really want to match this to the Meaningful Use 3 process, which really means as soon as possible, as was said by Leslie Kelly Hall the other day. And the contingencies, we feel like there aren't a lot of contingencies to move forward with this now. This is an early step. As we saw, there are a lot of tools in the tech demo yesterday, and so we think we can move forward with some of these standardization right now. So feedback, questions, Sharon.
So the deadline for meaningful use was like
Yeah, microphone.
All right.
We still have people on webcast, correct? Susan? Do we have people on webcast still?
Are people on the webcast?
Oh, okay, great.
Okay.
Great. We'll use the microphone because they're...
Sure. Sharon Terry, Genetic Alliance. So the deadline for Meaningful Use 3 engagement was weeks ago.
Okay.
Although Leslie and myself and several others are really concerned that we get this in as fast as possible. So any direction and recommendations as they're rolling, we can incorporate, because these our little tiger teams and groups and stuff are meeting already. The other thing I would say is under your purview entities, certainly entities that are already relating to this, so direct C-disc, HL7 purveyors, et cetera, all should be involved in this, and not to make it unwieldy, but let's not reinvent any wheels because there's already some stuff here that's really good.
Well, and we're hoping some of these answers also came from some of the other groups, but how do you spell C-disc?
CDSC.
Okay, great.
Clinical. You meant the Clinical Decision Support Consortium, right?
No, C-disc,
Oh, the other one.
yeah, CDISC. So both of them.
I hate acronyms. What was the other one? CDISC and
CDSC. Okay. Yeah, which is why CDSC doesn't like to be called CDISC, because there's a CDISC, CDISC. So, and if you're not confused now, right. So, we're blind. So, two things. First of all, the data activation group clearly endorsed engagement with meaningful use and put that to you as the data collection group. So we're on board with that. The second issue, this relates to the form scanning that you're talking about. I think the other thing that underlies meaningful use, and we heard a little bit about this, I think, from Josh yesterday, is the focus on the clinical document architecture, CCDAs, because that's a through underlying technology that is the meaningful use is using. And so I think creating family history as CDAs is going to be really important, because that will also then fit into the continuity of care documents. And Grant, can you remind me the status of the HL7 CDA for family history?
Well, the CDA that's produced.
Oh, yeah, just come up here. It's closer.
So CDA has a very specific implementation, and that is to recreate the current text-based clinical document, but turn it so it's they take the different data on that text-based document, codify it, so now a computer can not only can a human read it, but then a computer can see the codified data in that same document. So CDA doesn't specifically, there's not a CDA implementation that is specific just for family history. So as an example, in oncology, they've developed a template, a CDA template, that wants to talk about cancer information about a patient. Part of that information about that patient, they want to include family history information. The issue that we're working with on CDA is that template wants to say this patient has this relative with this cancer and this relative with this cancer, but the CDA does not include a full pedigree in it. So one of the things that we're trying to work on is we agreed that template, that CDA template, would also include a link back to that full pedigree. And so that's the status of that.
So to me, that suggests a specific action item, which is an inventory of all CDAs that involve family history, to make sure that all of them are organizing around the pedigree. So Kevin,
let me jump in just for a second. So there are two HL7 standards for family history: the pedigree model and the CCD model, or CDA model. They're developing a third family history model called the FIRE model. Both the FIRE and the CCD model cannot be used for clinical decision support. They don't contain enough information. So we have to push the pedigree model for family history, push CDA to fix CDA so it can accept the pedigree model, but do not use CDA family history because you're screwing yourself.
Haven't you somewhat done that, where in the risk apps you can see your data either as a pedigree or in tabular form? So it takes the HL7 pedigree and can flip it either way.
Correct. Yeah.
Yeah. So
it's the HL. Sorry, it's the HL7 pedigree model is the one you need to use for this. That's what it comes down to.
I'm one of the task force people, and I think, and this is definitely in the realm of magic, that we were also talking about all of the wonderful written pedigrees that our genetic counselors have already done. Is it possible to scan pedigrees and get them into the record? So I just want to make sure that was another part of it.
Okay, so the task force should absolutely discuss those specifics, but our view is we need to form some group to get down to those specifics and make a recommendation right away.
Under stakeholders, I wanted to make a plug for adding public health agencies, public health policymakers, both at the data collection stage and in the data connection and data activation stages. These are the agencies that are responsible for monitoring health disparities and barriers in access, so we need to remember that the patients who are captured in the clinical data systems, that there are patients who are uninsured, and it's those public health agencies that are responsible for monitoring health disparities and providing care and linking those populations who don't have coverage to care. So this information is going to be really important to helping public health officials plan for and monitor health disparities.
Great, excellent.
And James, moving back to your first slide, I want to make sure you understand what it means to make a paper family history form. These scannable forms are not cheap. The scanners are not easy to maintain. They are not easy to install. They're not easy to work with your EHR. So what it comes down to is that if you're talking about somebody funding a way to make paper family history forms, you're wasting your money. And there's nobody out there doing it currently. Well, there are people out there doing it currently, but nobody's doing it very well. I'd be cautious in recommending making a paper form.
Well, so it's not blue, which meant that it's not our high priority because we didn't think it was easy to do. Okay. But it would be interesting to put it out there.
Fair enough.
You never know what a developer with free time might think that's a great challenge to do. Who has students?
And I was also on this team, and since a lot of the people that are potentially going to be on this task force, and we want to do this ASAP, may I suggest we touch base at the end of this conference if anyone's available?
Great. So where should people meet to talk about that?
Here.
Right. Okay. Right up here, right up front. Anyone that's interested in participating in a task force to make meaningful use recommendations in the next few weeks, please meet up in the front afterwards.
Thanks.
That sounds like an action item. Okay. So, okay, moving on. The second area of outcomes were really data privacy protection and patient-controlled preferences on data sharing, kind of the two sides of a coin. The actions that were looked at were establishing a privacy bureau, a PayPal for privacy, so to speak, to review, and part of that we added in was to review privacy regulation that allows sharing and existing solutions in this area. The other actions were standards that label where information about family originated from. So once we allow sharing between family members, we need to know, did that come from my uncle's family record, or did I contribute that information about my uncle? Because that is very important. Also, standards for what types of limitations, legal limitations there are for sharing, but also requirements for that type of privacy bureau for regulation and transparency. Also, communication tools and standards for contacting family members. So not only for collecting and incorporating their information, but also for in medical systems for reaching out to family members, especially across state lines and outside the medical system. And then also a review of policies that govern information from deceased individuals. So the blue one is the one we chose to look at, and we thought it is the purview of HIPAA and HIPAA experts and the government entities that manage that, legal experts, privacy advocates, and institutions that are holders of data, meaning current purview, And stakeholders, all of the above means all the ones mentioned on the previous slides under stakeholders. Certainly this is the realm of patients, but also providers and other groups interested. The timeline, we thought there were multiple benchmarks for this, but the first really should be matched to the meaningful use development, because a lot of the standards that we're talking about, we need to at least be thinking about how those would be impacted if we're talking about sharing information between family members and not just data standards from an individual sharing family history data. So we want to be having some forethought on that, but then also the next steps would be to do this review of existing solutions and legislation, and all these are supposed to be 2 years, so we would hope it falls within that. Any other comments from my group on this, and or questions?
So we also actually talked about this paradigm in our new solutions as to how we would actually use the data, these data, and I have concerns about the PayPal paradigm. I think that patients are going to be less likely to use that than they will if they're with their provider, or if they're in their. I mean, if I send off a request to my mom to get her data, she's never going to look at PayPal. She's 80 years old, and she's never going to even have anything to do with that. Whereas if it was sent through the medical record and she was sitting with her provider and she had the opportunity to authorize that, to me, that I think they would be more likely.
So to clarify that, then, what we mean is an intermediary software, not so it could have an interface that you could go to, certainly like PayPal. But most of the way PayPal works is you never see PayPal. It's just a transaction.
Mm-hmm.
And so that was the thought, so that it would work with electronic medical records. But very much like PayPal or like credit scores, for instance, it only works if there's standards, but there's also a couple people that it's centralized in. Meaning there can't be like 50 companies or 50 government agencies that have a privacy bureau. It really has to be more centralized than that. So that was the thinking, that something like this would allow patients to granularly set their privacy preferences and change them over time, versus the current system where it's either blanket consent or it's nothing, or it's people afraid or misinterpreting HIPAA and how HIPAA applies to the data.
So I understand your point. I use PayPal, no problem there. I'm just saying, I think that with medical data, I think they're going to want more granularity than they would, for instance. I just think that there's concerns. You've got mental health issues. You may want to let people know about your TBI or your amputation, because they can see that, but they're not going to want you to know about your mental health issues. And I just think it has to be much more granular. And I think your task force will obviously have to do a lot of thought, and maybe we can combine your task force with our new solutions task force.
Great. That sounds great to me. Excellent.
Yeah, representing the activation group, again, this was an issue that popped up for us. The feeling of our group is that we got to get the EHR out of the mix because they're way too regulated, and then we think for activating data that the sharing is probably going to have to take place much in the way that you've talked about. So privacy and security was at the top of our list, and so we proposed an inventory, which I think you're proposing as well. The point that I would add is you need to actually add in states because there are state privacy laws that impact this that can vary, and so that needs to be those need to be understood as well. But just to note that we're concordant with your recommendation.
I looked up there and I didn't see anything representing the sharing advocates. So there's the privacy and security folks, and then there's the open sharers. So making sure that their voice is heard. There's been a proposal within that group of folks that the DMV shouldn't just ask for organ donation upon death, but also data donation. There's a whole bunch of people who do a complete data download that was not de-identified upon death. And right now we have no solution to that.
Does that capture that sharing advocates and open data? Great.
Thank you.
Excellent. Okay, so the next one, the third area is incentives for patient completion of family health history and education for patients and providers. The outcomes being setting national goals around population that have completed a core yet to be defined, family health history information in a record. an engaged patient and family, and then Healthy People 2030 goals for family health history data. And we kind of incorporated these together a little bit. The actions are those, but also to encourage research funding for family health history utility through white papers, gap analysis, promotion of existing research, and to create a task for what do we call this, the Family Health History Research Network, to do that. The third, and the reason we didn't select that one is because the State of Science report was in some ways supposed to really push that, but it didn't quite get there. But we thought there's still some value to that in trying to get more funding for this type of utility research. And the third one was get back to the basics, which is there are some new players that might be more interested as we develop standards in this area for funding more broad-based educational activities, and so we should be open to that. And education and awareness is important. So the one we chose, though, is the Healthy People 2030 goals and other state goals and objectives that exist, and really doing a review of those. For those of you that don't know, Healthy People 2020 are national objectives, health objectives for the nation. And not only do they set objectives that are used for funding and evaluation, but they also set what the national data sets are. And so the data that's collected in a lot of national surveys is actually linked to the Healthy People 2020 goals. So they do matter because you tend to develop programs and initiatives based upon existing data. So the thought was that this was certainly the purview of HHS, and whatever the group is that does Healthy People 2020, which I'm not 100% sure about. I know they come together for 2030, and that process will start relatively soon. But the stakeholders are obviously much broader than that, including a lot of the public health community, county officers, and all of the stakeholders that we said earlier. And the timeline, we need to investigate what the Healthy People 2030 timeline is. And we also, though, need to investigate what are these other essential state and national, or even within health system and health system society, objectives that we could influence to include collection of family health history. I think I inhaled a little bit too much marker. I'm losing my voice. And then the contingencies are a lack of baseline data. So Healthy People 2020 requirements require, though, that you have baseline data. And this is a tough one. There are some national surveys that were done, but there are not that many of them. And then also, we need to determine what is a reasonable objective. Like, what's a core data set? Is a core data set of family health history what we actually want to include? Is it, that that information is available in a personal health record or an EHR? Is it that your doctor has made a decision based upon your family history information? What actually is that goal? And we need to determine that. So, any questions or thoughts from the group?
Yeah, Bruce, James, you need to include also the societies and the certifying bodies. QOPIS was the Quality Oncology Programs Initiative, I think, from American Society of Clinical Oncology. We added measures there that have been piloted now of the percent of oncology patients who've had a family history taken, and the percent of those patients where the age of diagnosis was available, and the percent that were sent on for genetic testing. So that's some of your baseline data, but it's already in existence in some societies.
Excellent.
And I would be more specific than HHS because the Healthy People project is actually tasked to CDC, and the family history objectives that have been added in there are under the purview of the Office of Public Health Genomics, and so Moeen has been actively involved in creating the ones that are in Healthy People 2020, and I'm sure would be very interested in moving forward. And there are ongoing CDC surveillance surveys that information can be added to potentially to get some of the baseline data that would be necessary to add into Healthy People 2030.
Great, excellent. Okay, and so I think we're a little bit over our time here, and there are two other groups. I will just say that the other outcomes we discussed, just so you know, are expanded core data set for family health history to include occupational and environmental information, so talking about that. But also the opposite of that, which is where is it more valuable to us to collect broader data sets and then siphon out the medically actionable family health history information? So if you're collecting genealogy and health history is part of that. Where is that there's more of an incentive for people to fill that out, and then we can just pull out the information that's useful versus just saying, oh no, we just want the family history information. The second one was lab results linked to patient email or blue button. This was around genetic testing results. Patient voice incorporated into EMR through meaningful use mandate. Using family history as a toe in the door. There was discussion of a public family health history clearinghouse as another alternative, and then also to survey EHR and PHR users about their priorities for features and conditions covered. And this was to the vendor's point that they really follow the needs of their customers. And so we need to have a better idea of what the needs of the customers are in a quantitative sense so that we can publish that data. So thank you very much. And thank you very much to my group, who was absolutely awesome, for putting up with me for 2 days.